My pleasure to discuss with you this morning the use of EV1000 in early surgical recovery and fluid management for complex hepatobiliary surgery. This is a study done at the Mission System in HCA, North Carolina. There's no disclosures for this study. It's important to understand goal-directed fluid management. Fluid management is critical in the introduction of early surgical recovery protocols. And for hepatectomy, there are three distinct stages. The first being preoperative, intraoperative, and post-transection resuscitation. It's important to understand these and determine how best they can impact complications and the impact of patients long-term. As part of the ESR program, we invested in Edward Life Science System and deploying these throughout the entire hospital. We looked at adequate tissue perfusion and goal-directed fluid therapy, particularly in the three phases of hepatectomy. What we did was, in our methods, we analyzed the impact of the introduction of the EV1000 system on targeting, both the pre, intraoperative, and postoperative fluid management. We also looked at our first 30 cases compared to our prior 24 consecutive cases. These were done with traditional invasive monitoring. Data was then analyzed, and then we evaluated clinical outcomes utilizing SAS for statistical analysis. When we looked at patient population, the traditional invasive monitoring line is first, followed by the goal-directed therapy with the EV1000. You'll notice that these patients are very similar in the composition: age, gender, cancer incidence, incidence of minimally invasive approach, and major resection performed in these patients. Next, you'll notice that overall, there were very similar trends. OR times were similar, as was transfusion rates, length of stay, and overall complication. However, the complications such as ATN and acute renal failure were significantly different for traditional monitoring. There was about a 13% incidence of transient ATN or ARF, as opposed to 0% in the goal-directed therapy. This would indicate that there was better management of pre, intra, and postoperative fluid management using the goal-directed therapy. In addition, we looked at the readmission rate, and this was reflected similarly, that there was a 17% incidence of readmission with the traditional invasive monitoring, whereas 0% in the goal-directed therapies. So when we looked at these study outcomes, it becomes apparent that there were no major differences in the overall Clavien-Dindot complication rates. However, there was some significant differences in those things such as acute renal failure and transient ATN, as well as readmission rates. Of note, there was only one mortality in the entire group, and this was in the non-EV1000 group. But these, again, were very similar statistically. So when we looked at the overall thought process, the introduction of the EV1000 was a very critical component of our early enhanced recovery program, particularly in hepatectomy and advanced biliary disease. Our experience indicated that the EV1000s accurately were able to assess the volume management of the patient. We made critical changes and differences in the management of these patients, thereby decreasing their incidence of transient ATN or transient renal failure. And these then resulted most probably in lower readmission rates. This clearly demonstrates the value of early enhanced recovery and the utilization of the EV1000 or non-invasive monitoring system. Further studies will be necessary to really demonstrate the full adequacy and the value of these across the entire HCA system. We thank you for this opportunity to present this data, and we are open to any questions one might have.